everybody. I'm Alexandru Mischie, cardiologist in Montlucon, France. I'm the chair of the Tele-Cardiology working group on telemedicine from the ISFTEH. I have the pleasure today to have very special invites which will talk about the EuroHeart project, which is an ESC project, European Society of Cardiology project, aimed to develop a new IT registry. First of all, I would like to present the panel of speakers. We have Professor Aldo Pietro Maggioni, which is the director of ANMCO Research Center in Italy, and the scientific coordinator of the EURObservational research program of the European Society of Cardiology. We also have Professor Lars Walentin, Department of Medical Sciences from the University of Upsalla, Sweden. I would like to salute both of them. We also have the pleasure to have exceptional moderators, Professor Hany Ragy, which is a consultant cardiologist and the head of the department at the National Heart Institute in Imbaba, Egypt, and Professor Alessandro Sionis, which is the ACVC-ESC Secretary and the director of invasive cardiac care unit at Hospital de la Santa Creu in Sant. I hope I pronounced it correctly, Alessandro, at Universitat Autònoma de Barcelona in Spain. So thank you to all of you for accepting my invitation. I will just try to share my screen, and then I will invite the speakers and moderators to take discussion. I will just try to share my screen in order for 1 minute, just to present the Tele-Cardiology working group and the society, International Society for Telemedicine and e-health. So I will just try to do that right now quickly. So the International Society for Telemedicine and e-health exists to facilitate the international dissemination of knowledge and experience in telemedicine and e-health, and to provide access to recognized experts in the field worldwide. We have in our network 103 countries with more than 40,000 members. And there are several working groups, and here you have the most active working groups from the International Society for Telemedicine and e-health. You can request the affiliation to the society by sending us an email. And to finish, the International Society for Telemedicine and Cardiology working group in Tele-Cardiology structure has new members starting today. So Dr. Mihai Trofenchuk, which is the communication director, Dr. Ahmed Monsen, which is ambassador for Africa, and Dr. Han, which is ambassador for Asia. I'd like to congratulate all the three of them for this excellent nomination, and the great projects will come next. So I will give the word to Professor Lars Walentin for him to start the first presentation. Professor Walentin.
Thank you. I will now try to share my screen. So the EuroHeart project, this was really starting around a year ago. So we have been working on the first phase of development over the last year. EuroHeart is a project within the European Society of Cardiology, and of course the European Society of Cardiology had many years experience of running registries, and during the last 10 years the EuroHeart program, but over the last year there has also been a tremendous success of continuous quality registries, in contrast to the temporary registries that EuroP is running, also with a full coverage of all hospitals as performed in Sweden and UK. And there have been discussions around the quality of data from the observational registries within the ESC. And based on this experience, ESC has now concluded after these 10 years that there is a need to improve the quality of the observational data coming from the ESC registries, and also to expand the scope of the program to include support for quality development for the individual hospitals participating in the registration, and to also include device monitoring, which now is an EU regulation that companies need to provide information on new devices and new drugs. And finally, to start European projects with registry-based clinical trials, as already have been done in Sweden and also the UK. So the aim is really to start a learning healthcare system where we at the European level should be able to continuously register what we are doing, the processes of care, and to evaluate ourselves continuously over time, what happens in clinical reality. And based on this self-evaluation, there will be realizations of the need for quality development when comparing between centers. There will be obvious needs for new treatments that can then be translated into clinical trials, the same with new diagnostic methods, and sometimes we need basic research. And of course, this will lead to changes of scientific evidence and guidelines. So we hope that this EuroHeart system should really serve the development of cardiology at many levels. The idea is to use the same system that we have in Sweden and also in UK and several Northern European countries, that we have national healthcare databases based on personal identifiers. And if you are allowed to merge registry-based data with those national databases, we can have continuous information on patient characteristics, their treatments, and their long-term outcomes. And you can just see as an example from Sweden, where we have 107 different quality registries in different healthcare areas, and where we can merge the data with hospital admission registries based on ICD coding, with pharmacy prescription registries, with electronic healthcare records, and with the population registry. And you can really track a Swedish citizen from the first hospital admission until death, and have information on all follow-up hospital admissions, diseases, procedures, and treatments. And this is what we are aiming for to establish also in other countries. So the rationale for the EuroHeart system, it is an ambition to improve European cardiovascular care. And based on that, in Sweden and UK, we have more representative databases, and we have information that can support continuous quality improvement in all participating hospitals. And for that, we use continuous data collection. We have online reports on the processes of care that's immediately available. There is a focus on common cardiovascular diseases and intervention, and this has led to publications showing the improvement of quality of care and outcomes. And EuroHeart is mimicking this Swedish and UK system, really focusing on continuous data collection in participating centers and countries, common cardiovascular diseases, using IT systems and providing optional IT systems that can give immediate feedback to the users, and thereby allowing the monitor and influencing quality of care on a day-by-day basis, not periodically, but continuously. And this is just an example of the data that's available from the EuroHeart system, where you can see to the left the development over 20 years in treatment of ST elevation AMI, and where you especially see the development from 0 until almost 80% concerning coronary angiograms, PCI, dual antiplatelet treatment. You can see the increase in statin treatment from 10% up to 90%. And to the right, you can follow continuously the reduction in overall mortality and cardiovascular mortality, the two black lines, the reduction in MI, the red line, reduction in heart failure, the green line, etc. So you can see that there is a parallel development in improvement in treatment and improvement in outcomes. But of course, another reason to start this just now is the new alternative for randomized controlled trials, to have randomized controlled trials embedded into registries where you can continuously test the eligibility of all patients, and you have a continuous CRF running based on these high quality data entered in the registries, and where you can have more or less automatic follow-up by merging the databases with public registries, and you have complete follow-up. And by that you can perform pragmatic randomized controlled trials in a very general patient population, include all comers, not selected patient populations as in many of our current RCTs. And of course, a pivotal example here is the TASTE trial, the first registry-based large-scale trial that randomized in one single country 7,244 patients during 2.5 years to a thrombectomy catheter versus no thrombectomy in patients with STEMI. And of course, the outcome was neutral. There was no utility of using this catheter, even some harm. But this could be provided, this information could be provided within a very low-cost trial that changed care dramatically in a short time frame. And this was then considered by the New England Journal of Medicine as the next disruptive technology in clinical research. And now around 20 of those trials in different areas are run in the Swedish system, and they have also been transferred to other countries like the UK. And now we have the new EU regulation, a requirement to continuously monitor new cardiovascular devices, and we have had that also for some new pharmaceutical agents. So we need to provide post-marketing surveillance, and that's usually done by the companies, but there is a definite advantage if it was done within the healthcare system, within these type of registries. You have non-selected patients, non-selected centers, no really influenced by the sponsors, and you have a control population, not only the population treated with a certain device, but the control population with other devices. So this is a third component. And this is just to show you what happened with the thrombectomy device. To the left, you have the very variable uptake of thrombectomy devices up to around 50% of centers. You have the randomization period between 2010 and 2013. And then when it was shown that these devices were not useful, you have the rapid reduction in the use of these devices. So you can monitor the use, and you can also monitor the complications. So thereby, Professor Maggioni will explain the more details of the system.
Yes, the mission of EuroHeart is to develop and maintain the international collaboration among the different ESC countries, with the aim to support a continuous improvement of quality of care and the continuous improvement of the outcomes of patients with common cardiovascular diseases. This project will also include the safety surveillance of the new drugs and devices, and also the possibility to plan and conduct a registry-based randomized clinical trial. And differently from the trial shown by Professor Lars Walentin just a few minutes ago, in this way it will be possible to conduct registry-based randomized clinical trial not only in one country, but in multiple countries in different regions of Europe. Can I have the next slide, please? Next. Okay, to go in more detail, EuroHeart project is based on the development and the collaboration between national programs to use a common data set and quality criteria, and to support the continuous development of quality of care based on a continuous data collection on an individual basis. And as we said also before, there will be the possibility to have modules for drug and device surveillance and to have tools for developing randomized clinical trial and providing a common IT infrastructure to all the participating ESC countries. Next. So the idea is to cover the most common diseases in the cardiovascular field, such as acute coronary syndromes, MPCI, heart failure, valve disease, and atrial fibrillation. To do that, a data science group was created with the aim to identify the variables for each one of this data set, and to define the quality indicators and to define the definition of the different variables. The idea is to start with a pilot phase, including 2 to 4 countries, and of course the representative of the interested countries will be part of the development of the initiative, and they will be part of all sub-committees. Next slide. And this slide shows the structure of the EuroHeart. At least for the pilot phase, the European Society of Cardiology will be the promoter and the funder of the initiative, but with the help also from the industry, the research foundation, and hopefully also from the EU. An oversight committee has been created with the aim to evaluate the activities of the project, and the project will be conducted by an executive committee, and the executive committee is chaired by Professor Walentin and Professor Barbara Casadei, who is, as you know, the current president of the European Society of Cardiology. Then the member of the executive committee will be the chairs of the different subgroups of activity under the project management of Ebba Bergman. The different groups are the Quality Registry Coordinating Group, chaired by me, and this group has the aim now to evaluate the different countries in order to select the first pilot country to participate in the project. Then there is the data science group with the aim to define the variables, to select the variables, and to prepare the data collection. And this group is chaired by Professor Chris Gale from Leeds. And then there is the technology group chaired by our colleagues in Upsalla, Sarah Oldman and Håkan Oldfield. And in the near future, we will have also the group to expand, to implement the registry-based randomized clinical trial, chaired by the most experienced person in this field, that is Stefan James. And we will have the module for the drug or device surveillance group, chaired by Alan Fraser. Of course, the different countries will provide their own representative for all these committees. And this is the situation of the countries of the ESC. In green, you can see the countries in which this kind of platform has been already implemented: Sweden, Iceland, United Kingdom, and Scotland. In yellow, you see the countries in which there are already systems for collecting data continuously, at least for acute coronary syndrome. So for this country, the decision will be to move from their own platform to the EuroHeart platform, or to maintain their own platform, but to use and share the same data variables. And the other countries are the countries to be selected for the pilot phase of implementing the IT platform locally. Next slide. We started the contact with the different countries during the month of July of last year, and we continue to have a Zoom meeting also in the period of the COVID pandemic. We had some delays, but the activities were not stopped. And now it is possible also to define among all these countries which could be the candidate for the pilot phase. Next. Just a few words regarding the EuroHeart Data Science Center that is based in Leeds, chaired by Professor Clis Gale. The aim is to prepare the standardized data set and to coordinate the statistical analysis. Up to now, the variables for the EuroHeart ACS and EuroHeart PCI has been completed, and there is the discussion with the representative of the different countries. So we will have between 50 and 100 mandatory fields to be collected during the procedure of PCI or during the hospital stay for ACS. Then we have different modules, a module for optional variables for ACS and optional variables for PCI, and in each country these variables can be selected and also added according to the need of the different countries. And then a module for the drug and device monitoring and the module for the registry-based randomized clinical trial will be developed with the aim to have the possibility to link all this module with also the national data in order to have information of the outcomes without collecting specifically this kind of information by using the national data. Next slide. With respect to the platform, as it was mentioned before by Professor Walentin, the basis is the platform developed in the University of Upsalla, the UCR IT platform. And on this platform, the EuroHeart registry platform have been developed. And now this platform will be developed in the different countries, starting from the pilot countries. The EuroHeart platform will provide the countries with the necessary know-how. It will support the development of the different modules, and at the local level, at the national level, it is very important to have IT people in order to develop the system locally and to continue local training and to maintain the system over time. Next slide. And it is my last slide with the timelines of our initiative. In the second quarter of 2020, so just yesterday, the idea was to take the final decision on the first pilot country and to develop the platform for ACS and PCI. And yesterday we decided that the first country will be Estonia. The executive committee decided that Estonia will be the first country. In the third quarter of 2020, we will decide which will be the second pilot country, and the finalization of the protocol and the variable for ACS and PCI will be concluded. And we will initiate the development in pilot country 1 of the platform. In the last quarter of this year, 2020, the IT platform will be developed in pilot country 1, and probably also the third pilot country will be selected. And in the third quarter in 2021, the EuroHeart ACS PCI registry will start collecting data in the first pilot country, and also the activities on the next clinical area, that is chronic heart failure, will be started, and protocol and variables will be decided. And in the second quarter or 2021, we will start the application of the heart failure EuroHeart project. And the most important probably quarter will be the third quarter of 2021, in which at the ESC Congress, we will present the first data collected in the pilot country. And finally, before the end of the next year, the finalization of the long-term project will be decided, and also the confirmation that the EuroHeart project will continue for a long period of time after the pilot phase will be finally decided and validated. So you can have some information on the web page of the ESC. There is a link to see the initiative of EuroHeart. And if you want additional information, there is also a specific email. And now we can move to the EuroHeart movie to show you more detail and practically which could be the content of the experience. Please, Lars.
Okay, so let's see if we can show you a movie showing the practical work with the system. And then I share my screen again, and we say share here, and we try to start the movie.
Welcome to this demonstration video of the EuroHeart registry. EuroHeart is a European collaboration with the aim of continuously collecting data about cardiac diseases such as acute coronary syndrome, heart failure, valvular heart disease, and atrial fibrillation. Suleiman will now start demonstrating the EuroHeart registry and the development process so far.
Thanks, Graf. Let's now start the demonstration of the data entry process for both acute coronary syndrome and percutaneous coronary intervention. To enter data to the acute coronary syndrome registry, we first select the unit, then identify the patient, and then select the admission tab. Under the admission tab, 4 sections can be completed, including basic patient details, comorbidities relevant to acute coronary syndrome, as well as some basic information about the presenting symptom, important dates and times relevant to the presentation, as well as basic parameters at the time of hospital presentation. Following the admission details, we will now show the data entry process for in-hospital care data. The in-hospital care details can be entered using the in-hospital care tab, which include basic results, biochemistry, the results of the left ventricular ejection fraction, as well as any coronary assessment, treatments including anticoagulation and type of reperfusion therapy, as well as any complications or events happened during the hospital stay.
A unique feature, and in order to ensure the comprehensiveness yet simplicity of the EuroHeart registry, was the early decision during the development process to include two types of variables: mandatory and optional variables. Mandatory variables are the core essential EuroHeart variables that all participating countries have to collect. In addition to this, the optional variables are predefined variables that countries can pick and choose among depending on what they want to collect. In addition to this, the EuroHeart registry allows for country-specific variables depending on the individual need of the country. We will now demonstrate the remaining part of the EuroHeart registry platform.
Thanks, Graf. Let's now move on to the data entry of the coronary angiogram findings and the percutaneous coronary intervention procedure. Coronary angiogram and PCI details can be entered using the Angio-PCI tab, under which basic demographics and comorbidities can be entered. These comorbidities have been auto-populated from the admission section to avoid duplication in data entry. The following section include medications at the time of the procedure. After that, information about the coronary angiogram procedure, including the indication, urgency, as well as important dates and times, and some technical information about the procedure. Following that, the findings of the coronary angiogram can be collected, including any abnormalities in any of the coronary artery segments. The next section captures information about any PCI procedure, including the attempted segment, the type of the procedure, and the equipment used. After the PCI details, information about the complications during the procedure can also be collected.
The final step in entering data into the EuroHeart Acute Coronary Syndrome Registry is done under the Discharge tab. We will now demonstrate how that is done. On the Discharge page, patient details at discharge is collected. This page includes details such as discharge date, final diagnosis at discharge, but also medication provided to the patient upon discharge. This page, once collected, can easily be saved or signed. Before signing this page, I just quickly wanted to show you these green eye icons. This is where you can find information about each variable collected. Once signed, this page can be easily accessible and reviewed by people having access to this database. This page can then also be printed out if needed. When logging into the EuroHeart registry, you have access to two pages: registrations and results. It's within results you can find the production and the quality panels. This is where you can find results being collected. In the production panel, you can find results from your own healthcare unit in plain numbers. This page is highly customizable depending on what numbers and what data you have collected that you want to analyze. In this demo, we're illustrating number of patients registered within the database. Next to the production panel, we have the quality panel. It is within this panel you can find the quality indicators being collected. In this demonstration, we have reperfusion and time to reperfusion as two quality indicators being collected. You can find more details about the results for these quality indicators if you scroll down. You can again compare results to previous years by changing year up here. This data can also be easily saved into spreadsheets if you want to further analyze the quality indicators and the corresponding findings. So this was a quick tour of the results page within the EuroHeart registry. We're all very excited about the development process of the EuroHeart registry so far. To conclude, EuroHeart is a scalable registry with the aim of being comprehensive, yet a simple registry that can be utilized for a variety of purposes, including data collection, quality improvement, device monitoring, observational research, and registry-based randomized clinical trials. We're all working towards the same end goal of improving European cardiovascular care. And with EuroHeart, we open up possibilities for collaboration that we never thought was possible before. Before ending this recording, we would like to acknowledge the hard work done by the EuroHeart team, the reference groups for helping us in developing these variables, the IT team for developing this platform, and ESC for supporting this important project. Thank you.
Okay, I think no one could have said it better. So I think this concludes our presentation of the EuroHeart.
Well, of course, I'd like to thank you both, Professor Walentin and Professor Maggioni, for sharing with us this exciting program. It's a lot of information to take in, and together with, of course, my co-moderators, I will start the discussion. If you, I'm sure we all have some questions for you, and also whoever is in the audience is also welcome to ask questions through the question and answer app, which you will find at the lower part of the screen. So I do have a question for you, Lars. Could you just, and of course, Aldo also for you, but it's, we've been seeing ESC registries for a long time now, even for the past years under the Europe umbrella. What are the main differences that you could just point out between what we will have in what we're starting to see now with this new project and the past?
I can try to answer, Lars, to this question. Being involved very strictly to the EURObservational program. The two projects are really very different in the sense that the tradition of data collection of the ESC was based on temporary registry with the main aim not to improve the quality of each center participating in the registry, but to have a broad idea of the level in the different countries of the level of adherence to the recommendation of the ESC guidelines. And for this reason, they were planned more or less a couple of years after the publication of the guidelines, with the aim to see how in the different countries these guidelines are implemented. EuroHeart has a different aim. It's based on a continuous data collection with the main aim to improve the quality of care in each participating hospital, also through a benchmarking with the other hospital of the same region or the hospital of another country or the whole project. So There is also the possibility to do observational research to put together the data, but the main aim is to work locally to improve the quality of care.
So you could say that in a way we are shifting from a single frame picture, one shot picture, to a continuous flow of information that will allow to improve the quality of care that is delivered even locally.
Exactly.
And it's also, I mean, another difference is that what's in it for me is an important question. And I think it's a large difference for the participating hospitals because they can use the data immediately. It is, I think, really that the EUR program and even EuroHeart service, the real aim was publications, produce publications, and we know what is the situation in Europe some years ago. But what we need is online data today for my center to change healthcare until next week. And you can compare to the COVID situation. We can describe the weaknesses, what happened in COVID in a few years from now, but we are not interested in that. We need to change the COVID situation until next week. And for that reason, we need immediate data. No one would be happy with just noticing that in Sweden we have much too high mortality. Why is that? Why is that? We need to measure today. We need to change it until next week. So this is kind of the concept, and you need to do it everywhere because the situation is very much different in different parts of the country, and it's very different. We have seen this in the different hospitals. It is like fingerprints. Some are performing well, some are performing poorly. There is no Swedish average. There is no European average. So this is what we like to.
It's really interesting what you're saying. I think that my co-moderator, Professor Ragy, Hany, has a burning question for you. Hany, you want to step in?
Yes, hi. I would like to thank you for the presentation and the video. It was very informative. There's a significant spectrum of data collection in Europe, and Egypt is actually part of the European Society of Cardiology. So we have countries like Sweden, which collect data on all their medical data on all their citizens from birth to death. Even if they migrate to Australia, you can still get their data. And countries like Egypt, which have a very primitive data collection. So for the countries that have excellent data collection, how are you gonna implement this in their hospitals without having to enter the data twice and have the resistance of too much work for data entries? And on the other side, countries like Egypt, in which we don't have databases, can we adopt this as our national database permanently, or is it a time-limited project like some of the EuroHeart surveys? Was my question clear?
Oh yeah, you are quite clear. It's a very, very interesting question. And I think the system is fairly flexible. So therefore, it can be implemented in countries that already have excellent electronic healthcare records, as we have in Sweden, because what we are providing is not text. We are producing a CRF. We are producing structured data that can be immediately analyzed, and that's not even available in Sweden. So therefore, if we can combine this itemized registration with the information we have in other public registries, that is really a strength. The system is able to import and export data from electronic patient records. So we do this if we have these items accepted in the electronic healthcare records. We really import or export, and we try to avoid repeated data entry. And as you saw, the system that we showed you, we try even in our own system to avoid repeated data entry. And I mean, for a heart failure registry and ACS registry, many patients will be similar. So this will be a transfer of data from one to the other. But of course, it will be challenging. We think, though, that this optional database might be ideal for countries like Egypt. Yeah. You would really get an information system that's extremely useful directly. And parts of the documentation in the Swedish system, and that will be the same in the EuroHeart, you can print out and use it as part of your documentation, like coronary angiograms, procedures performed, medications provided. So I think in many different environments, and also that, I mean, the resources needed in the country is that you have your own IT center with 3 to 5 people that is tailoring the system to your healthcare.
Right.
If I can add just one word regarding your question, that is very important, as also Lars said, to have a national system, it is very important, in my opinion, to have some collaboration with your health authorities.
Yeah.
And probably in a large country such as Egypt, it is not easy at the very beginning to have all the hospitals of the country collecting data, but it could be very useful and interesting to start with a region, with an area of your country, with the collaboration of the health authorities in order to make this system the system of collecting data in that area, and then to expand to the other part of your big country.
It would actually practice our country to a totally different level. It's almost like a dream coming true. Thank you.
Yeah, I think we think that there are countries with special needs for this system that don't really have any standardized documentation. So we think, and ESC also thinks, that we should especially focus on less privileged countries for the system. I mean, Germany might not have such large needs, but many other countries really have large needs.
Lars, can I ask you a question about who is actually in charge of the input of data in Sweden? Is it the doctor, the nurses, whoever is involved in the clinical process?
Yes. So all are involved, and it's somewhat different. But for coronary angiograms and PCI procedures, it is the interventionalist or an assistant, and it's done during the procedure. So, and the system provides online information, and it also produces a report that can be sent to the patient records and back to the ward, and also to give to the patient. In the wards, it's mainly the nurses or an assistant entering the data. It is not always online. It might be done at nighttime, later. So within a week or something.
So the idea is not to overwhelm a single person with all the data. It's just you keep on adding little by little for each single patient. So everyone contributes.
Yeah, the best is that it is done rapidly. And if you don't have a computer available, you can have a paper form, you fill it in, and then you can give it to an assistant entering it. It's done in some registries also, but the ideal is that you enter it directly, because you have the best information on these data, like ECG interpretation. You know the patient. This is what we think.
Hany, I think we have a couple of questions from the audience.
One is from Mihai, who's the new communication advisor to the group, and is asking, can some local centers, for example, in Eastern Europe, become part of the registry project, or is it only possible at the level of national involvement? Thanks, everybody.
But for example, in some big countries, the idea is to start just in a part of the country. For example, in Italy, just one region, Emilia-Romagna, we start. In Spain, probably just Catalonia we start, with the aim to start with a region and then to enlarge the project to all the other regions. I think that if the project works, there will be a great interest also for other countries and other regions in the same country to participate, because it is a system that really can provide an improvement of the quality of care, but also statistics of your activity, and to see how your activity is changing over time and day by day?
Actually, in the United States, as far as PCI at least is concerned, the NCDR registry, which is run by the ACC, is giving them the benchmarkings and pretty similar to that. But hospitals have to pay a significant amount in US dollars per year to be part of the NCDR registry. From what I understand, the European registry is not going to be, at least in the beginning, a profit generating. I mean, how are the costs going to be covered?
I think the cost is, we think, national. So there needs to be a center responsible for the registry. They need to have some IT people, depending on the size of the country, between 3 and 5. There needs to be some monitors that checks the quality of data entered, of course, and probably a project manager overall responsible. So this is the main cost, and that will depend on then the salary cost in the countries. And then to run this IT system, will be a license fee. It's let's say it's fairly low, I must say. We haven't exact amount as yet, but it will be a low cost in the pilot phase, probably even lower. So I think, but there will be no cost for the individual centers as far as we see.
And the general idea of EuroHeart, Hany, differently from the ACC, is based more on the disease than on the procedure. So the idea is to have continuous data collection on ACS, heart failure, atrial fibrillation, and inside these clinical areas to have information regarding the procedure performed, but in the context of the disease, not just the data collection on the procedure.
Excellent.
So we also have 3 questions from the audience here. One, I think it's quite interesting, is how will the EuroHeart handle the patient identifiers in the context of course, the local laws and of course, I think you already thought about that. That's one easy issue to solve.
No, we always get this question, and these systems are national. So there is no international repository of individual data. They are national, and it's up to each center, each country, to follow the laws of their country. For quality development, at least in Europe, there is no need for informed consent. You need to inform the patient that this registration is ongoing, but for quality development, there is no need. The data stays in the country, and this international benchmarking will be based on aggregated data. So all countries analyze their own data and provide the aggregated data to the data center. It will be like kind of a meta-analysis that you can see different results in different countries. And there will be a synchronization, a coordination to do the data in the same way in the different countries. And then for randomized clinical trials, of course, then there will be informed consent. And in this type of setting, the system will develop a parallel database for this type of data. But then the patient have given the same type of informed consent as for any randomized clinical trial. So
that's right, because you have anticipated the next question. So it's this is very interesting. So you will only need an informed consent in the case of randomized clinical trial.
Following the usual rules of research.
Yeah, of course.
Country by country, because are different.
Another question is, but I think there is not a clear answer for this, but what cardiovascular risk scale or risk punctuation will be used? I think from what I've seen in the video that you can actually come up with different risk scales according to the need of whatever study you're running.
I think that we have all the variables to use the different scale of risk. And this is true for ACS and probably would be true also for heart failure and atrial fibrillation.
Yeah. And then you could probably reconstruct.
I'm sure there will be some investigators inventing the EuroHeart risk score system, and this will be publications in 5 years from now.
Sure, I'm sure about it. I'm sure about it.
There's a question which keeps coming up, even though it was presented quite clearly in Professor Walentin's presentation, which is how the data is going to be used to conduct registry-based randomized trials. And I think you gave an excellent example on taste and the thrombus aspiration, but maybe you want to elaborate, because it seems Aisha Kaider, our friends from Bangladesh, has just posted the question again.
Yeah, we have learned a lot since the taste trial, and I think to participate in the registry-based randomized trial, you need to have the system, the optional IT system. It's like you have in every clinical trial, you have a predefined database handling the data with lots of automatic checks, etc. And this system, of course, will use the same variables. You might add some optional variables that needs to be filled in, and outcomes you get from national other public registries. But simultaneous with the registration, at the end of every day, a parallel database will be formed. And in this database, you have the informed consent. This data will never be removed. I mean, the patient have given informed consent, and you have a complete database until the patient eventually is arguing that he likes not to be part of the trial anymore. So therefore, I think this way of handling it, there will be a parallel database exactly following the rules of a clinical trial.
Right. Thank you.
Great, thank you. Good discussion. Alexandro, you want to step in now? Because I think you had a question.
Yes, thank you very much. Thank you to all of you. So I would have a question for both of you, for Lars and Aldo. Why did you select Estonia? Is it because it has one of the most developed IT medical infrastructure?
Yes, this is one of the reasons. They have a very mature system of informatics, and it is just one of the reasons. The other reason is that there is a very enthusiastic team inside the National Society of Estonia, and this is another good reason. Another reason is that it is possible to develop the system in the most important university of Estonia with a collaboration with the health authorities in order to make possible the linkage using a unique identifiers with the national data. And another reason is that it is a small country, so it's good for a pilot experience. And lastly, it was a country not particularly affected by COVID, so it was possible to discuss with them and to start the initiative very early, while in other countries there are still restructuring the situation after COVID. So there are several reasons. And in any case, Estonia was decided yesterday as the first milestone, is the first pilot country.
I understand. So one question for Lars. Lars, what would be the ideal requirements that you would ask a country or a region to have in order to access the project?
Yeah, I think you need a group of people who likes to support development of quality of care in their own healthcare system, in their own hospital, to focus on that. You need good leadership, you need lots of enthusiasm. I think all the practicalities can be overcome and supported. You can find the IT people, but you need the leaders, you need the enthusiasts, and you need a group of centers. And this is more or less idealistic. I mean, it takes a long time. You don't get immediate publications. The rewards are not immediate. So this is a long-term commitment. but I mean, obviously you have the chances to be the leader of quality development in certain areas of cardiovascular care in your country, which is very rewarding.
We understand. If maybe Alessandro or Hany would like to highlight any other ideas or questions.
There was just a couple of last questions. One was from Mihai again. Which resources are needed for the implementation, accomplishment of these tasks? It was partly said, but maybe you want to touch on it quickly.
To be clear, there are no resources to be paid to the ESC, as you mentioned, for the ACC experience, just local resources.
Okay.
The IT people, a clinical monitor and the project manager, and a license at a very low cost per year. So it depends, of course, the dimension of the resources depends on the level of the salaries in the different countries. But the resources are based on some people working on the project.
And it should be emphasized that these resources stay in the country. So these are national. There is no request for any payment to ESC outside this license fee for the IT system. But otherwise, the resources that are spent is national, and they are spent on your own people.
If countries which are not members of the ESC, countries in in Latin America or deep in Africa would like to join, is there an access?
Very welcome after our pilot phase, of course.
Thank you.
Alessandro?
I think it's been a great presentation, and I don't have any more questions. I mean, everything is clear. I want to participate, but let's probably.
We need the leaders everywhere, you know.
Probably there, actually.
And then you can usually a certain persuasion of other centers to please join us, and let's try.
So
me too. I did not think that sorry.
I'm saying that in Barcelona, we are looking at this interesting project very closely, and hopefully we will be able to participate in the near future.
Yeah, I did not think I would actually live and see the day where a country like Egypt, which actually has reasonably good medical care, but terrible data collection, very rudimentary. But this could take us to a totally different level. I mean, you know, I can't wait to join. And I think all my colleagues share my passion.
Thank you, everybody. So I think it's time to end our excellent session. Alessandro, I noticed you have some guitars in your bag, so maybe next webinar we would love to end it maybe by a Barcelonian song.
Please invite us. Webinar.
So it has been a great pleasure to have you all as invites and speakers. I'd also like to thank Chris Gale, which could not participate today. And I'd like to state that this webinar was followed by at least 150 people on Zoom and Facebook, because we had a broadcast on Facebook Live also. And once again, I would like to thank Lars. I would like to thank Aldo, Alessandro, and Hany. Thank you very much for taking 1 hour of your precious time to discuss on this project. And I hope to see you again. Please keep us updated with any news you have regarding the project.
For sure.
Please follow the website.
The website is updated.
Is the video available on YouTube?
On the website, on the website, yeah.
On the website of the, okay. Thank you.
Okay.
Thank you very much.
Thanks a lot.
Bye. Thank you.
Bye.
Bye. Bye.